Today I am presenting a case of 63-year male, automobile mechanic by occupation, Hindu by religion from Amarpur, Tripura. He belongs to low socioeconomic status BPL family, came to us on the date of 15 September 2023 and examined by me on the date of 17 September 2023. He came to our hospital with presenting complaint of Willis discoloration of eyes and urine for 4 months and generalized itching for 1 month. History of present illness. The patient was apparently asymptomatic ago when he noticed Willis discoloration of eyes in the mirror. The discoloration was insidious in onset, gradually progressive and deepening over first 2 months, followed by diminution over next 1 month and deepening again for last 1 month. This was associated with high color urine, color increasing progressively, and clay color stool for the same duration. Continue to history of present illness. The patient also complained of generalized itching for nature. There is history of significant weight loss in last 2 months. There is history of loss of appetite for last 1 month. There is history of passage of black tarry stool for 2 month back, which lasted for about 7 days, with Willis discoloration of eye and urine subsided. Continue to history of present illness. There is no history of pain abdomen. There is no history of vomiting or hematemesis. There is no history of episodes of fever with chills and rigor. There is no history of lumbar abdomen. There is no history of breathlessness, hemoptysis, or bone pain. There is no history of any drug intake. History of past illness. There was no history of blood transfusion or surgery. There is no history of diabetes mellitus, hypertension, tuberculosis, or asthma. There is no prior hospital admission. Personal history. The patient is a non-vegetarian diet, reduced appetite, sleep affected due to itching. There is no recent alteration in bladder habit, stool are clay colored. Patient is a chronic consumer of alcohol, consumed 3 days in a week, about 180 ml brandy per day for last 40 years. The patient is also a chronic smoker. He used to smoke 20 pack years. Family history. There is no history of similar illness in the family. There is no history of known malignancy in the family. Summary of the history. A 63-year male, old gentleman with no history of comorbidity, presented with progressive jaundice, high color urine and clay color stool for 4 months, which was associated with generalized itching for 1 month. Patient had melena 2 months back, which was followed by diminution in intensity of jaundice. He also had significant loss of weight and loss of appetite for a month.
Hriday?
Hello, sir.
Yeah, can you hear me?
Hello, sir. Yes, sir.
Can you hear me?
Yes, sir. I can hear you, sir.
Okay, just say yes.
Hello,
okay.
Sir.
There is a gap between
Yes,
or a lag between what I speak and what you hear. Okay.
He's almost in near Bangladesh, sir. That's why.
No.
Yes,
what I'm trying to tell is just respond. So we'll go to the first slide. Okay.
Yes, sir.
Okay.
Sure, sir.
For the benefit of every one of you, please make your presentation in a PowerPoint presentation. Have you done it in the PDF format?
Yes, sir.
Have you done your presentation?
Yes, sir.
So please do it next time in the PowerPoint presentation mode. Okay.
Sure, sir.
Okay. Number one. Number two, this is for the benefit of everyone. Please put some slide numbers for all of your slides. Okay. All right.
Sure, sir.
Okay. So now you have a 63-year-old male. Let us go
Yes,
straight to the
sir.
presenting complaints. Yes, hold on here. So yellow discoloration of the eyes and urine for 4 months and generalized itching for 1 month duration, correct?
Yes, sir.
Go to the next slide, third slide. Up, move up. Yes. Now this is how it is. So
Yes, sir.
incidence in onset and you have mentioned, and there was some diminution over next 1 month, correct?
Yes, sir.
What is it called as?
Yes, sir.
What is it called as? Hriday?
Sir, it is progressive jaundice. Jaundice is progressing.
What I am trying to tell is,
Hello, sir.
to avoid this confusion of Aditya Chobe is mentioning as intermittent jaundice, I just want to bring your attention, all the students, between the difference between intermittent jaundice and fluctuant jaundice. Okay. Now, what is intermittent jaundice, Hriday?
Sir, there, in case of intermittent jaundice, there will be period of jaundice, and there in between, patient will be asymptomatic. Like there will be jaundice followed by the patient. After some days, the patient will be asymptomatic, and again there will be jaundice.
Just don't use the word asymptomatic. What I am trying to tell is the jaundice completely disappears. Okay. In intermittent jaundice,
Yes, sir.
jaundice completely disappears. Can you give me one example for this problem?
Sir, in case of choledocholithiasis.
Very good answer. So this solves Aditya's question. So intermittent jaundice means jaundice will come back to normal. So why does it happen in choledocholithiasis, Hriday?
Sir, because of the stone blocking the CBD, common bile duct, result in spasm of the CBD, which will result in the colicky pain and leads to the inflammation of the gallbladder. When this inflammation subsides, and jaundice also subside.
No. You
This
brought
leads to this intermittent jaundice.
Hold on. You brought gallbladder into discussion. Don't bring that. We are asking for jaundice now. So stone probably can slip out, number one. Stone probably can move up and down. And when the inflammation settle down, the naturally the whatever compression is there inside, I'm talking about intraluminal, pressure also will come down. So pain, fever, jaundice, all will disappear. And this triad is called as, Hriday?
Charcot's triad.
Very good.
Charcot's triad.
Since we brought this into discussion for intermittent jaundice, I will just ask quickly, what is Raynaud's pentad?
Sir, in case of Raynaud's pentad, there will be intermittent pain, intermittent fever, intermittent jaundice, along with the severity of the symptom. Like the patient will have shock and patient
altered mental status. You know, most of them have a high-grade fever and even chills and rigors. Okay. So now in your patient, so that is what probably we would like to ask you, whether the jaundice completely disappeared or it is only diminished. See the word diminished. So what is it?
So patient, it was like jaundice was present, like it was persisting.
So what is
progressing?
So what
gradually?
1 minute. What is it called as? Yes.
The word used is, what sir is expecting is waxing and waning of the
yes
jaundice. Okay.
So what I want to tell you is
waxing.
It is a fluctuation you are finding here, waxing and waning of the jaundice. And then it has started becoming deep, correct?
Yes, sir.
Can you tell me, when this happens, did your patient notice any important color change in his clay colored stools? When this episode of diminution happened, this happened.
Yes, sir. The patient noticed red color stool, passing of red color stool.
So you don't get that red color stool because the, blood has to come from all the way from duodenum, second part till the rectum. So it's some kind of a
black starry
Yes.
stool. Black.
So that is what you should tell. So if this clay colored stool plus this blood added, what is that called as?
Yes. It is silverish color.
So very good. It's also called as aluminum paint or ogilvy stools. Anyway, so your patient has what is called as a fluctuant jaundice. So it is not intermittent jaundice, number one. Waxing and waning, it's characteristic of what disease, Hriday?
Sir, it is suggestive of a benign
Suggestive of?
lesion.
Sorry?
Benign lesion. Sir, it is suggestive of carcinoma of ampulla of butter. Periampullary carcinoma.
So it's typical. Why does it happen?
Carcinoma.
Yeah, why does it happen?
Sir, because of the mucosa leads to this waning of the symptom.
So central necrosis,
periampullary mucosa
sloughing off, necrosis, because relative ischemia to the center. So that is what happens. So typically you have a patient who has got a fluctuant jaundice here, and that is the time he passes clay colored stools was passing earlier, and then he is now passing with the melena, correct? Yes. Can you tell me why do you get clay colored stools? Why do you get clay colored stools?
Sir, because of the obstruction in the biliary pathway, the bile from conjugated bile cannot descend down into the intestine, and it cannot be converted into stercobilinogen. That's why this clay color stool is formed.
Good. So both urobilinogen as well as stercobilinogen is absent. Normally you get stercobilinogen. So here it is not there. So you get a typical. It has been mentioned as clay colored stool. It doesn't have to be real clay. Sometimes the color may change. Okay. Can you go to the next slide? We have to move a little bit. Yes. Now you tell me, he noticed this yellow discoloration of the eyes. So tell me at what level of jaundice you will notice this, bilirubin levels.
Sir, above 2.5 milligram per deciliter.
So above 2 plus, you may notice that sclera will get, attached to this. So that is why the patient has noticed. What is the cause of the generalized itching?
Sir, because of the deposition of bile salt in the dermis, that is the subcutaneous tissue, it leads to the irritation of this nerve ending.
There's some liberation of the histamine from the mast cells.
This leads to this.
So with that irritation, you get intractable pruritus. What is the significance of this intractable pruritus?
So this leads to this feature of obstructive jaundice. Because of this obstruction, the bile salts level is increased in the systemic circulation, and these bile salts are deposited inside the dermis layer and leads to this release of this histamine from the which result in this irritation of nerve.
Listen. Hriday, well done. But what you should know in the examination, When a question is asked, answer to the question. I didn't ask you what are the entire pathogenesis. I asked you one simple question. What is the importance of knowing this intractable itching? One, it is disturbing his sleep, correct?
Yes, sir. Disturbs sleep.
You already mentioned one, it is obstructive jaundice. Second, disturb the sleep. Does it
Yes,
have
sir.
any bearing in the management?
Disturb the sleep. Yes, sir.
What?
We have to preoperatively we have to remove the bile so that the symptom is symptomatic relief. We can give the symptomatic relief to the patient.
What do you mean by removal of the bile? Hriday?
Hello, sir.
What do you mean by removal of the bile? So,
The
okay.
draining.
Draining
of this.
We will talk about it later. Indication for preoperative stenting. If you don't have an immediate date available for surgery and different reasons, this intractable itching becomes one of the indications for the biliary decompression. Suppose you want to do it after 2 weeks or 3 weeks, that is the type. Okay. So anything else? Would you like to mention here points in favor of malignancy in this slide?
So there is history of weight loss in this patient, significant weight loss for the past 2 months.
How much?
Sir, it is more than 10% weight loss for the past 6 months. It is significant.
So now we can change to the next slide. Go up.
Yes, sir.
Yeah. What is the importance of this word pain abdomen?
Sir, it is pain abdomen rule out from the benign causes like CBD, choledocholithiasis.
Suppose I say this. Yeah, suppose I say this patient has got also backache. Yes.
Yes, sir. It can be related due to pancreatitis also. It may be due to cholecystitis also.
No. Don't. We'll talk only about our patient. I say backache, you have to answer. Sir, I would like to know where is the pain felt? Shoulder blades means CBD stones.
Yes, sir.
Lower back, not lower back, I'm sorry, thoraco,
Yes.
upper back here. That could be a carcinoma body or even a head region if it is advanced. Third, in advanced patients, metastasis. Okay?
Yes, sir.
And
Yes.
Rarely, I'm just keeping you, be careful. Rarely, sometimes, since there is a periampullary lesion, it can itself precipitate an attack of acute pancreatitis. Okay?
Yes, sir.
Right. So this is what few things you should know. Now, what is the importance of this word hematemesis or vomiting?
Sir, to rule out the other causes of GI bleeding, upper GI bleeding.
No. Don't
like
bring
portal hypertension.
Okay, alcoholic ferro, very good. I will give you marks for this hematemesis because you would like to know esophageal varices. But more importantly, what is the importance of knowing this vomiting? It is not due to metastasis as somebody. 1 minute. It is not due to metastasis as somebody is putting there. Vomiting is probably due to, can you think vomiting due to relate to head of the pancreas and duodenum? Can you give me the answer now? Yes. Yes. Hriday? Hriday is there?
Sir, can it be due to cholestasis? Like,
What I want to know, tell you is that head of the pancreas, when they enlarge, they will produce second part of the duodenum obstruction. Okay. It also can grow up and cause
Yes, sir.
pyloric obstruction. So you know that in that situation, if it is inoperable, I use the word inoperable, your duty is not only to drain the biliary system, we have to also allow the patient to eat something till the last. So a gastric bypass is required. So you should know about this vomiting. What is the importance of
Yes,
this fever with chills and rigors?
sir, fevers with chills and rigor rule out the
Cholangitis. Okay, please remember when you use the word, yes, somebody has put it infection, correct? Cholangitis. And cholangitis is more common in
cholangitis.
common bile duct
CBD obstruction.
correct? It is common in
Yes,
CBD
sir. CBD
stones.
stone.
It's more common in CBD stones than malignancy. All right. Breathlessness, hemoptysis, bone pain are not all that common. Doesn't matter what drugs you are interested in. Drugs. What drugs?
Sir, hepatotoxic drug like rifampicin, anti-TB drugs, and the
Yes. Yes. Antipsychotic
anti-malarial
drugs, sulfonamides, chlorpromazine,
antipsychotic
chemotherapy
drugs.
drugs, etc. Can we change the next slide, please?
Yes, sir.
Go up, go up. Yeah, so I think we will not, it's almost about 30 minutes now. Go to the personal history. Personal
Yes,
history.
sir.
So before we go, that one important thing in obstructive jaundice you should know, in the past history or whatever it becomes, sometimes history of present illness itself, any history of surgery in the gallbladder. Why should you know this?
Sir, it may be due to like previous history of any cholestasis. It may be a feature of CF and CA gallbladder.
Cholecystitis is not related to gallbladder carcinoma. Quickly to tell you, any surgery in the gallbladder, when we say yes, somebody has beautifully mentioned as stricture. So post laparoscopic cholecystectomy or bile duct stricture, that should be your answer. See, because in your university examination, when you are given an obstructive jaundice patient, they won't tell you it is due to stones or periampullary or head of the pancreas. It could be a patient who has undergone cholecystectomy. So your answer should be bile duct stricture. Okay? Clear?
Stricture. Yes.
Clear? Hriday?
Yes, sir. Yes, sir.
Yeah, because there is, I think, a gap. All right. Among this in the history, non-vegetarian,
Yes, sir.
1 minute, non-vegetarian, alcohol, smoking. Which one you think is a cause for the carcinoma pancreas in general in this list?
Sir, sir, here the alcohol can cause CA
Which
pancreas.
it is not alcohol, it is
Chronic.
smoking. Okay, right, we'll go. All have been blamed, alcohol,
Yes,
smoking, but I asked you in this, most probably it is smoking. Okay, all right, go ahead. Next. Yeah, just one line for this. Can pancreatic cancers run in family?
no, sir. Yes, sir. Pancreatic cancer run in family, sir.
Yeah, it can run.
Yes,
okay. Sir. I think just a little bit may not be common. It can also have a periampullary lesion, yes. Some polyps there, polyps in that area. BRCA mutation. Next.
BRCA2.
So at this stage, what is your diagnosis, Hriday?
Sir, in this case, I am thinking about it is a case of obstructive jaundice, most likely to be due to malignant etiology.
Your answer should be here. Obstructive jaundice, probably due to, you can straight away tell waxing and waning is present. So I would like to consider ampullary or a periampullary lesion. Okay. We don't want to consider head of the pancreas here because there is no pain, correct? No pain at all. All right.
Wait, no pain.
Okay, we will proceed.
Yes, sir.
Yes. Kishan, is it any questions are there in the chat box you want to ask or something, or anyone? I can't talk. Can I? Or shall we go ahead? Yeah, go ahead. Hriday, go ahead.
On general physical examination, patient is conscious, oriented, and cooperative. He is moderately built, fully nourished. His BMI was 19 kg per meter square. There was no sign of dehydration. Icterus present, no pallor, no cyanosis, clubbing, polyonychia, generalized lymphadenopathy, and edema. There was no sign of liver cell failure. Scratch marks were present all over the abdomen and thigh.
Yeah, just quickly, just
Vitals,
hold on.
He was afebrile, 60.
What are the signs of liver cell failure you are looked for?
Sir, I will look for the from head to toe. Like there will be alopecia, there will be caput medusa in the abdomen. There will be
just hold on.
gynecomastia.
1 minute for the benefit of everyone who is here. See, don't mix up two things here. Liver cell failure versus evidence for portal hypertension and also cirrhosis. I am not trying to split the answers, but try to understand. Tomorrow, a patient with the alcoholic cirrhosis comes and says alopecia. Do you suspect liver cell failure?
No, sir.
So I think all of you well in medicine. Please be very clear. Evidence of cirrhosis includes, can you tell me the list today?
Yes, sir. Pulmonary edema, Dupuytren's contraction.
Yes. Yes.
There will be ascites in this.
Gynecomastia is there. Evidence of cirrhosis. Evidence of portal hypertension. Can you tell me?
Portal hypertension.
Very good.
Splenomegaly.
And yes.
Variceal.
Don't say varices.
Hepatosplenomegaly.
We can't see esophageal varices, so you can tell caput medusa. Okay.
Okay. Yes.
What is the evidence of liver cell failure? Yes.
Hello, sir.
What is the evidence of liver cell
failure?
There is
no pulmonary edema.
What I wanted is flapping tremors, encephalopathy. We say no patient is oriented well in time, person, all that thing, right? Okay.
Yes, sir.
So yes, I hope you'll make a small note of this. Evidence of cirrhosis, evidence of portal hypertension, and evidence of liver cell failure. So you will find a different three things. Just quickly tell me, what are the components of portal tributary and what are the components of systemic tributary in caput medusa?
Sir, in there will be left gastric branches and there is superior mesenteric vein. There is a branch from the superior mesenteric vein.
Hold on. Don't go to very deep. Caput medusa is very, very superficial in the abdominal wall. So what are the systemic component? Superior and inferior epigastric veins. They are the systemic. Okay. And what are the component of portal?
Epigastric vein.
Veins run in the falciform ligament. Okay, all right, proceed. Let us proceed.
Yes.
Next. Please.
Sir, on systemic examination,
those
examination
are-
of
yeah.
abdomen.
Yes, go ahead.
On inspection, abdomen is flat. Umbilicus is central in position in inverted corresponding quadrant of abdomen, move equally with respiration. There was no visible lump, peristalsis, scar or dilated vein. There was no left supraclavicular fullness. All the hernia orifices are normal. Spine is normal. On palpation, superficial palpation, no rise in temperature, no tenderness. On deep palpation, liver is palpable 5 cm below the right costal margin at the mid-clavicular line, which was soft, non-tender, smooth surface, rounded margin, and firm in consistency. A firm, globular, non-tender lump palpable in the right hypochondrium with a smooth surface and well-developed border, which moves with respiration. There was no other organomegaly. On percussion, liver span was 12 cm in the right mid-clavicular line. Abdomen was tympanic, note, and hard all over the abdomen. There was no shifting dullness. On auscultation, normal bowel sound, hard. Review to other system, CNS, S1, CBS, S1 and S2 hard, no added sound hard. CNS, no focal neurological deficit found. Respiratory system, normal vesicular breath sound hard, no added sound hard. On rectal examination, it was not done as patient not give consent to me. Summary to the case, a 63-year-old gentleman present with progressive jaundice, high color urine and clay color stool for 4 months, which was associated with generalized itching for 1 month. Patient had significant loss of weight and loss of appetite for a month. On examination, he was found to have deep icterus and malnourished. On abdominal examination, gallbladder is palpable, which is smooth and firm.
Yeah, can you?
So my provisional diagnosis is this is a case of obstructive.
Can we go to the
my provisional
general physical examination next, that inspection slide, inspection.
Yes.
Okay. For the benefit of everyone here, abdomen is flat, all that I have seen now. What you have to mention here is no dilated veins, you have mentioned, no peristalsis and no lump. So don't get into the trouble of mentioning peristalsis in your patient. As usual, examiners may ask you what peristalsis. What peristalsis, Hriday?
Sir, it is the normal bowel movement.
I know that you will, so you will not find the normal bowel movement, okay? So you should know what are you looking for. That is the exact reason I asked this question. I think little homework for all the undergraduate students that, yes, somebody has pointed out the...
Sir, gastric outlet obstruction.
Very good. Yes.
Excessive bowel movement will be there in case of gastric outlet obstruction.
I think your terminology in the gastric outlet obstruction, just say left to right. It's called as VGP. Don't use the word bowel movement. It is the visible gastric peristalsis. Don't put that word olive-shaped mass. Who has written that olive-shaped mass? That is got only in the idiopathic hypertrophic pyloric stenosis in child. Don't bring that into discussion now. So that is only in a child. In an adult cicatrized pyloric obstruction, you will not find any mass. And carcinoma pyloric antrum, you get a mass. So don't bring that into discussion, because VGP, small step ladder pattern and colonic. So if you write peristalsis, you should know what you are looking for. Otherwise, you will be in trouble. Again, no scar means previous laparotomy scar or something, and it may have relevance. As I mentioned to you, do you know, Hriday?
Yes, sir.
Do you know, Hriday,
Stricture.
what? 1 minute, 1
Yes,
minute.
sir.
What incisions are put for a laparoscopic cholecystectomy? Yes.
Sir, laparoscopy, there was 4-port surgery.
Very good. Very good.
4-port are
I know.
placed. One is
know.
the
Yeah. So what I want you to understand is, if they ask you what scar you are seeing, your answer should be, I will look for laparoscopic cholecystectomy scars, because if patient has undergone gallbladder removal, probably patient is having a bile duct stricture. Is it clear?
stricture. Yes, sir.
Do you know that
Yes, sir.
earlier gallbladders are removed by what incision?
Kocher's incision.
Before laparoscopic days?
Sir, it was Kocher's incision. It's right
Okay.
subcostal Kocher incision.
Excellent, excellent. Right subcostal coccus incision. All right. Please remember, don't mix up now spine, supraclavicular, etc. When we talk about inspection, we start the abdomen as a full. All right. So all the quadrants, hernial orifices is part of the abdomen. Okay. But left supraclavicular region, you have to mention later. When we talk about abdomen, we talk about inspection, palpation, percussion, auscultation, which includes obviously hernial orifices. Then comes the external genitalia. Yes, rectal examination, supraclavicular, separately you have to examine. Similarly, spine, these are all specifically you have to look for in the evidence of metastasis. All right, there may be some difference of opinion. Doesn't matter. Next slide. I just want to ask you quickly here, since you have mentioned, you have mentioned liver is palpable and all the details you are given, why the liver is palpable?
Sir, because of this there is a slight hepatomegaly.
I know. I am asking you, hepatomegaly, you already written the liver. See, liver is palpable. Once you have written liver is palpable, I know why do you say liver. Can I ask you for why did you say it's a liver?
Sir, because it was not movable with the respiration and the margin.
Just hold on. Liver always moves with respiration. Okay. Don't confuse. Today.
Sir, yes, sir. It is margin is felt. It was smooth in consistency, margin of liver.
I think time is so. For the benefit of students here, why liver is palpable is an anatomical question. Means you need to know what is the anatomical structure. So it is in the hypochondrium, moves with respiration, finger insinuation not possible, percussion it is dull, continuous with that, and lower border is sharp. The second part, what he has written here is smooth surface, round margin. So what it says is a back pressure. What he said is hydrohepatosis. Correct. Now, can you tell me about this second one? What do you think that structure?
Sir, it is gallbladder. Most probably gallbladder.
Why do you say gallbladder?
Sir, because it is a globular mass and globular lump felt in the right hypochondrium. It is smooth in surface. It medial and the lateral margin is palpable, but the upper margin is not palpable, and it is moved with respiration.
Very good.
So most probably it is gallbladder.
So that is your finding in the abdomen, that a liver is palpable and gallbladder is palpable, correct?
Yes, sir.
So what you have written as no other organomegaly. What did you look for?
So I will look for the spleen.
Excellent. Why spleen?
Sir, it may suggest the portal hypertension.
Excellent answer. Anything else you look if you are suspecting a malignancy, whether it's a stomach or whether it's a gallbladder or whether it's a head of the pancreas, whether it's a colon, anything else?
Sir, any head of the pancreatic mass, palpable mass is felt or not? I will
All
look
right,
for.
very good. Excellent answer. It's not palpable. Anything else? What I wanted is some lymph nodes, paralytic nodes. All right.
Paralytic lymph node.
Where do you get paralytic nodes? Which
Sir, in
quadrant? Yes.
Epigastrium.
Excellent answer. Above the umbilicus in the epigastrium. Very good. Aditya Chobe has mentioned that testicular tumors, that is the causes of paralytic nodes. See, I asked a question to Hriday. Where do you get the paralytic nodes? He has given a very good answer, that is epigastrium or above the umbilicus. What are the causes of paralytic nodes? That is your testicular tumors, etc. All right. So, can we proceed to the next slide? Yeah, percussion. I think we have already mentioned about this. Liver will be obviously continuous. Lack of, we have to discuss some more. So we'll proceed now. Go to the auscultation. Yeah, normal bowel sounds. All right. Come next. So here, after this, you should mention rectal examination. You have honestly written not done. That is all right. But what do you expect?
Sir, on the par-rectal examination, on inspection, I expect that there some anal bulge. I will look for the anal bulge, fissure, any sinus. On digital rectal examination, I will look for the tone of the anal sphincter. In the lumen, I will look for any, if there is any stool, I will look for the color of the stool. Any growth, I will look for any growth, and any fecalith is present or not. Any rectal mucosa, I will also look for the rectal mucosa.
Just hold on. Examiners won't expect those so many things. That is fine. What we want is correlate to your case. Your case is a periampullary carcinoma as your diagnosis. You have written that sloughing has taken place. So when you are doing a rectal examination, first thing you should tell is color of the stool. All right?
Yes. Sir.
Second, is there a blood or not? Right?
Yes, sir.
Third, more important, the blood when I say melena. Third is, what is a Blummer shelf?
Blummer shelf.
Blummer shelf, you know, how you keep books in your shelf. What is that?
Sir, it is the cushion-like structure present in the anal sphincter. It usually enlarge.
Not maybe you know, but maybe you expression is a rectovesical pouch. Malignant deposits. You know, malignant deposits will happen in the transcelomic spread there. Can cause like a hard indurated lesions anteriorly. Indication of a inoperability, means the cure is probably not possible. That is why you should know. Okay, when I ask this question, since I have to also ask you, what are the signs of inoperability which you look in any patient who has got a GIT malignancy, including hepatobiliary?
Sir, it will spread to the other side, other organ.
Local spread is not a contraindication. Okay, I'll quickly give you the answer. Signs of inoperability. Liver metastasis, that's a nodular liver. Sister Mary Joseph's nodule. What is Sister Mary Joseph nodule?
Sir, it is the umbilical area. In the
Blummer shelf. Ascites, very important. Large paralytic nodes. So all this will add to your signs of inoperability. After that, you should mention about supraclavicular node, and particularly you have to make the patient sit and you go behind and palpate gently in the left side, especially left supraclavicular region. Okay, right? Yes. Come to the diagnosis. So only one or two questions to you. That what made you to give a diagnosis of periampullary? Now you have to start with the why obstructive jaundice. why? Yeah, I will quickly tell since somebody has asked a question. Signs of inoperability. Please remember, local tumor spreads to the other organ. You may resect it, so it doesn't come under inoperability. But a spread has occurred to the liver, nodular liver. Yes, Sister Mary Joseph's nodule. That's umbilical nodule. Rectovesical deposits. Paraaortic nodes, supraclavicular node, Blummer shelf, that's what is rectovesical deposits, ascites. All this will make whatever tumor, you may resect it, but it is not curable. I hope it is clear. So that's called as signs of inoperability. Now, Hriday, why obstructive jaundice?
Sir, from the history, we get the patient is having Wellish discoloration of the eye, and there is high color urine, clay color stool associated with the pruritus, generalized pruritus.
And yes, excellent answers. Yes, go ahead. So what you have to answer is, sir, as far as the history wise, these are the points to say obstructive jaundice, history wise. As far as the clinical examination, I found out scratch marks.
Scratch mark on the body.
And as far as the local examination of the abdomen is concerned, what did you get?
Palpable firm gallbladder is present.
So now you tell me what is Courvoisier's law?
Sir, in case of obstructive jaundice, if the gallbladder is palpable, is not due to benign cause, because in case of benign cause, the gallbladder will be shrink because of the.
Don't bring the word benign cause here, because benign can be many things. Just use the word stones. Okay. Stones. Because of that, somebody has pointed out that stones cause recurrent infection of the gallbladder. So the wall gets fibrosed, so it cannot enlarge. Remember, you have I always tell, happy birthday balloon is a thin, so you can blow. But a football bladder is thickly contracted. Contracted gallbladder will not enlarge. So in a periampullary carcinoma or head of the pancreas, gallbladder is thin walled. So it is palpable. But remember, it need not be palpable in all cases. Even sometimes up to 1/3, it is not palpable. Okay. So if you don't get a gallbladder palpable, it does not mean that it is not periampullary or head of the pancreas. Okay.
Yes, sir.
Okay. Now, next question to you is, why not head of the pancreas?
Sir, in case of head of the pancreas, there will be waxing and waning will be absent in case of head of the pancreas.
Yes. Yes. No pain.
There will be no
waxing and waning. Yes.
No. There it will be painless and it will be progressive, sir. In case head of the pancreas.
Head of the pancreas also can be progressive. Okay.
Progressive.
We are strongly in favor of periampullary because of sloughing. Otherwise, with the weight loss of very significant weight loss, we are more in favor of actually head of the pancreas. You understand? Yes. Periampullary lesions with this won't give a significant weight loss to that extent. Okay, doesn't matter at this stage. Last question before we proceed to the investigation is, whenever you palpate the gallbladder, what are the things come into your mind? What are the causes of enlargement of the gallbladder?
Sir, it may be the benign cause.
Tell what? Benign cause. What are the causes of enlargement of the gallbladder? 1, 2, 3, 4.
In case CBD stone, it may be the emphyema of gallbladder. It may be mucocilia of gallbladder.
Just hold on. Don't be fast. We just now said, if there's a CBD stone, do you get enlargement of the gallbladder?
No, sir.
Then why did you say that? So,
sorry, sir.
Yes. So first is, what is mucocele?
Sir, because of the obstruction of the cystic duct.
Very good. So you have a cystic duct, neck, that Hartmann's area, one large stone may be blocking it. I won't go into the depth of all the Mbbs syndrome, etc. Doesn't matter. One is a mucocele. Second is a empyema. My question to you is, most importantly, is I am not asking you all that, exceptions to Courvoisier's law that I think all of you will read. Why not carcinoma gallbladder? Why not carcinoma gallbladder?
Sir, in case of carcinoma gallbladder, in palpation, it will be hard in consistency.
Excellent answer. Very good, Hriday. So whenever you have a palpated the gallbladder, when you have a hard gallbladder with the obstructive jaundice, you have to consider with the significant weight loss, carcinoma gallbladder. Okay, to give you a little more marks, one little PG level question. Can you get a enlarged gallbladder in carcinoma of the gallbladder? If so, where should be the carcinoma arising from? Which part of the gallbladder?
So it in the neck of the gallbladder.
Very good answer. It's extremely common in the northern India where a neck is obstructed. Good. Hriday, you are doing good. Causing a enlargement of the gallbladder. Yes. Okay. I think we'll proceed to what investigations you will do now.
So to confirm my diagnosis, I would like to do the liver function test.
All right. What do you expect in that? Somebody has pointed out ERCP. Please remember, we should not mention ERCP at this juncture in a periampullary carcinoma. I will tell you the reasons. I'll come to soon. Yes, tell me. First, LFT. What do you expect?
Sir, in case of,
I can't hear you.
in this case, I expect that the conjugated bilirubin will be
Hello?
more than
Hello?
the conjugated one.
Am I audible?
Conjugated bilirubin will be more than the unconjugated one.
Hello?
Hello, sir.
Yeah.
Alkaline phosphatase level will be increased.
So conjugated bilirubin is
Yes, sir. Yes, sir.
will be more than 50%. Okay.
Increased.
More than 50%. Urine
Yes,
erupt.
sir.
If there is a increased alkaline phosphatase, what does it suggest?
Malignant. It suggests the malignancy.
Don't jump into malignancy. It only says that
Obstructive
yes,
pathology.
again, yes, you are read well, but you should answer well. More importantly, it only says that it is a malignancy. It is a not necessarily malignancy, obstruction. It can also be intrahepatic cholestasis. It can be a large mass which is compressing. All right. So there
Yes,
are many causes of a increased alkaline phosphatase. All right. Yes. LFT says increased alkaline phosphatase and bilirubin is 12, direct is 8. What is the next investigation?
Sir, I would like to do the USG abdomen, USG of whole abdomen.
Always, yes, somebody has pointed out PTINR. We definitely we have to do complete blood test. Increasing total count means infection. PTINR is important. Prothrombin, you know, the liver is the only source of prothrombin. So you have to get it done.
Prothrombin.
And patients have to be given vitamin K before surgery. If not, fresh frozen plasma. Now come back to, don't say USG. I will do ultrasonogram. Okay.
Yes, sir.
What is the first thing you will see in any jaundice patient when you send for radiology, especially obstructive jaundice?
Sir, I should look for the liver function test finding.
No, hold on. I am asking you imaging, ultrasound.
Sir, in the ultrasound, I will look for the any like anatomy of the structure.
We see, please.
In the biliary path.
I can't hear you, Hriday. So for the benefit of everyone, first thing you should tell in the exam is, I would like to see intrahepatic biliary dilatation. First thing. All right. Sonologist will keep the probe and tell first that intrahepatic dilatation. That means it is
intrahepatic biliary.
Hypoechoic lesions may suggest metastasis in the liver. Somebody
Yes,
has mentioned hepatic parenchyma, correct? Because patient is alcoholic, he may be having cirrhosis. You would like to see the left hepatic duct, right hepatic duct. You would like to see the lymph nodes at the porta hepatis. What is the tumor which happens at the left and right hepatic junction? Hriday. Hriday?
hello, sir. Can you hear me, sir?
Yes.
Hel-
Yes. Cat
Sir, it
skin
is the
tumor. Yes. Left and
biliary
right
radical cat skin tumor.
cholangiocarcinoma. After that, you come down, see the CBD dilated, normal, 2 millimeter. So here you may find 6 millimeter, 8 millimeter, 10 millimeter. Then you comment on the cystic duct, neck, then gallbladder. All right. Then come the
Yes,
lower CBD, stones, cholangiocarcinoma, portal vein, liver. So ultrasound is excellent. You can detect the full biliary tree up to the head of the pancreas. All right.
yes, sir.
When there is a head is enlarged, apart from carcinoma head of the pancreas, what else you suspect today? Yes.
Sir, it may be due to the any pancreatic mass. It may be the bile duct
No.
obstruction.
What I wanted was, apart from carcinoma head of the pancreas, you have to also suspect chronic pancreatitis with the head mass. That is one of the difficult problems to treat. We'll not talk much in detail for you. So you have to mention about ultrasound. This is the uses. Now, somebody has pointed out the ERCP. I'll come to that. After the ultrasound, what is the main problem of ultrasound?
Sir, it can in the terminal ileum, if there any stone or obstruction in the terminal ileum, because of the bowel shadow, it cannot delineate the structure correctly.
I don't know what you mentioned, terminal ileum or terminal CBD?
Terminal CBD.
So, operator dependent and the gas, two important problems. So, better is the CECT abdomen. All right.
Yes, sir.
So, once you are done the LFT, then you go for ultrasound, then you go for the CECT. Tell me one important precaution you would like to take whenever you ask for a CECT abdomen in obstructive jaundice. Yes, you are using a contrast. Yes, Aditya has mentioned correctly. Yes.
Sir, I should look for the creatinine.
Very good. Excellent answer. So hydration should be adequate. Hydration should be adequate and creatinine, so that people will not develop a renal failure.
Contrast induced.
Very good. Excellent answer. So what is that? Why do you want to do CCT scan?
Sir, in the CCT scan, I can look for the in the three phases there, like arterial phase, there is parenchymal phase and the
it's called a
venous.
Pancreatic protocol. Yes, three phases. Very good. Yeah, quickly summarize and tell what are things you look for.
Sir, I will look for the any neuroendocrine tumor in the vessels is not present or not, any parenchymal lesion is present or not, any tumor present in the portal vein or not.
I mean, it's all right. What I want you people to understand is that in addition to the advantage of the ultrasound, which have been mentioned, like metastasis in the liver, etc., 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 what I want you to tell in the exam is to see the periampullary lesion or a head of the pancreas, and for infiltration into the mesenteric vein and superior mesenteric vein and superior mesenteric artery and duodenum and the stomach. So the so-called the local infiltration. All right.
Yes, sir.
That much is enough for you people to say that I will do the CT scan. to rule out local infiltration. Obviously, next question examiner will ask you is why do you want to see the local infiltration of superior mesenteric vein, portal vein, the superior mesenteric artery. So then comes your answer for the radical surgery. We'll come to that later. Now that you are suspected a periampullary carcinoma, can you get a diagnosis by any other means, tissue diagnosis?
Yes, sir. I can do the percutaneous, like transhepatic.
No. Please. Whenever you have a lower obstructive lesions, lower bile duct. When I say lower bile duct, means lower CBD, duodenum, that area. Don't go to the PTPD. You have to mention ERCP. All right.
Yes, sir.
Again, I am
Yes, sir.
careful here. Aditya Chobe, it is not ERCP guided biopsy. Just say side viewing endoscope. Side viewing. You know why side? You know
Yes,
what
sir.
is
Because
side? Yes.
so from the upper GI,
Ah.
it view the side view in the periampullary region to see
Yes, always please whenever the question is asked on ampullary and periampullary carcinoma, please use the word I would like to do the side viewing endoscope and I am seeing the ampulla there and I am seeing a periampullary region which involves all that lower CBD, duodenal mucosa, pancreatic duct, etc. That one more. So you take a multiple 6 pieces at least for a biopsy. If you don't see any growth, if you see ulcer, you will take a biopsy. Then you have to give a small cut. And then you may find a lower CBD growth, take a biopsy. Last but not the least, brush cytology you can do. And for the benefit of everyone, please don't mention ERCP. Our answer of the periampullary carcinoma or ampullary is endoscopy, side viewing, and multiple biopsies or brush cytology. Even that comes negative. You have a head mass. Then I think we are going little higher now. Then you have to do endosono-guided FNAC. Endosono-guided, not PTBD. Okay? Yes. Not PTC. Endosono-guided FNAC. All right. I think endoscopic biopsy says, what do you expect? What do you expect, Hriday? Tissue histopathology?
Sir, any periampullary mass, we can delineate the structure like any periampullary. It is adenocarcinoma or other kind of.
Very good. So mostly it is adenocarcinoma. Where do you think that arises usually from? This
glandular
duct. It is usually from the pancreatic duct, ductal carcinoma. All right. It's usually from the pancreatic duct there. So when you have a diagnosis, you are confirmed and you are done a CT scan. So ultimately, you have to have a metastatic workup for a staging purpose. Staging. You heard of that word, staging?
Yes, sir.
I will not ask you the details about staging. It is not very important to by heart. It's always available. You can always refer. So once you have got a tissue diagnosis, I have done a CT scan. I have confirmed there are no liver mets. And most importantly, CT scan is done to know the operability. Operability means, as I mentioned some time back, operability, when I say local infiltration means you can remove. It is still operable, but when there is a supraclavicular node, I may remove. Then that doesn't become operable. That becomes resectable. I hope it's clear. All right.
Yes, sir.
If you are asked for the head of the pancreas, any tumor marker, if you know, what is the answer?
Sir, it is CA99.
Very good. You know the normal levels? It's just a curiosity. Up to about, say, around 5 to Normal, when I say the importance, yes, somebody has put less than 60, that's fine. 30 to 40, up to that you can consider as units per international liter, normal. And then, of course, as it goes very high, you suspect. That's a different issue. So, diagnosis of obstructive jaundice is done by clinical examination, history-wise, clinical examination. Then comes the LFT. Then comes the ultrasound, intrahepatic dilatation. And once that is done, you have made a diagnosis of periampullary carcinoma. Now, what is the treatment?
Sir, I would like to do the laparotomy for this patient to confirm my diagnosis.
1 minute, 1 minute. What did you tell before laparotomy? Yes.
Whipple's procedure. Sir.
No, 1 minute. What I want you to understand is, whenever you are asked to say, I will prepare the patient for surgery. That should be your answer. All right?
Yes, sir.
Do you know how to prepare the patient for surgery?
Yes, sir.
Tell.
I will check for the fitness of the patient.
Very good. What is the criteria which you have mentioned?
I will see her CBC finding, complete blood count finding.
No. What I want you to understand is, you heard of Karnofsky
score.
Or Sukriti has mentioned ECOG. What is ECOG stands for? Any idea? Doesn't matter. If you know it, well and good. This is a Eastern Cooperative Oncology Group. So just like Karnofsky, you have the other way is oncology, because you would like to involve the patient for chemotherapy, radiotherapy, etc. All right. Yes. One is that fitness, anesthesia, fit. Next, prothrombin is elevated. So what do?
I will give vitamin K, sir.
And if still it doesn't come down, it has what else?
Clotting factors. Fresh frozen plasma. FFP.
Very good answer. Fresh frozen plasma you will do. Very good. After that, if there's a hydration, patient is all right. So he's not dehydrated. So you give the antibiotic, prophylactic antibiotics are given, and you can nutritional if patient is all right. Albumin is important. I'm hurrying up a little bit, and you'll proceed with the. Before you say pancreatic or duodenectomy, your answer should be all operable tumors. Best is the surgery. All right.
Yes, sir.
Whenever doubtful operability of the portal vein, superior mesenteric artery, etc., infiltration, then you can mention about neoadjuvant chemotherapy. I think we will not go into the depth of that, but when you are mentioning surgery, you have to mention diagnostic laparoscopy. Why is that?
Confirm my diagnosis, sir.
No, you can't see the periampullary small lesions sometimes, or even a ampullary lesion by putting a scope. Diagnostic laparoscopy, you don't see, but you are doing it for something which
tissue biopsy.
No, tissue biopsy you are done with the endoscopic side viewing. Most importantly, what you can't make out in the CT scan. So is peritoneal nodules. They are all very, very less than you. Sometimes they are all 0.5 centimeter. When I say 0.5, means they are 5, you can say as a 5 millimeter size. So these are the ones which you cannot pick up with the CT scan. So if there are peritoneal nodules, small omental nodules, ascites at the time of, you always take it for biopsy. And then, of course, if it comes as positive, you have to treat it as a stage 4 disease. Is it clear?
Yes, sir.
It is a little more complicated procedure. So in a nutshell, I would like to tell you, when you are dealing with the stage 4 disease, your intent becomes, from the curative, it becomes palliative. When you think about palliation, then you have to answer, doing a Whipple's pancreatic or duodenectomy, advanced lesions for a palliative procedure, it is not worth.
Yes, sir.
Then you will do what is called as triple bypass if there's a duodenal obstruction. If there's no duodenal obstruction, you do a choredochojejunostomy and gastrojejunostomy. Is it clear?
Yes, sir.
So this is how you have to analyze the case. Dr. Kishan,